Shoot. All right, can everybody see?
Yes.
Okay, perfect. So I just want to say thank you, Romaine. I've been busy and haven't gotten to see a couple of these, but I have gotten all the emails, and me turning it over to you has done nothing but blossom Harry Barnes. So kudos to you. And I also want to thank Harry Barnes Society for letting me speak tonight. And we're going to talk about recalcitrant sinusitis. So I have no financial disclosures. And when I got the email, I said, sure, what do I have something, you know, a grand rounds type talk already prepared. And then as I went along, I realized there's a lot of information, and I could probably do a 1-hour lecture on just about anything I'm going to talk about tonight. So this is going to be very kind of high yield overview of hopefully different tips and tricks you can use if you have patients who you're struggling with as far as chronic sinusitis. How do you get them to feel better? How do you get their scope to look better to you? And then hopefully at the end, we'll be able to answer any questions. There is a request for me to talk about biologics. So at the end, we're gonna spend a couple slides talking about biologics and how I use them in my practice and kind of what the evidence shows. So tonight's objectives are to identify steps to optimize surgical intervention, to identify factors that may lead to surgical failure, and then to identify treatment options for recalcitrant symptoms. So anybody who knows me knows I'm a huge Buckeye fan. And so this is an homage to everyone who believes in the big blue. So this way, if you fall asleep, you can at least wake up when you see nice little highlight reels of the Ohio State. So we're going to start by how I manage and tackle chronic sinusitis. So when patients come into my office, really I start with 5 kind of ways in which I think about the patient. The first is I try to assign the right diagnosis. So are they a phenotype of chronic sinusitis with polyps or without? Now we have lots of endotyping type research going on, and probably in about 5 years, this talk will be very different because we won't be talking about whether or not a patient has polyps or not. We'll be talking about their eosinophils, we'll be talking about their genetics, we'll be talking about whether or not they're a type 3 inflammation. But right now, what most of us have access to is a scope that lets us say, yes, the patient has polyps, or no, they do not. So that's kind of where I start. And then I think about what are their comorbidities. So do they have asthma? Is their asthma controlled? Do they have allergic rhinitis? Is it patient complaint, meaning I have hay fever? Or did they actually get a skin test that said that they were allergic to something? Do they have aspirin intolerance? And then do they have cystic fibrosis? And on all of my kind of consult templates, I have a box that requires me to check each one of these before I can sign the note, because I want to try and make sure I'm thorough at the beginning. So if anything happens as we're going through the process of them healing from surgery or medical therapy, I have already asked the pertinent things, and I'm not going back to say, okay, did we talk about this? Did we look at this? So the next thing is optimizing preoperative sinonasal health. So I tell my patients, if your nose is very inflamed, it's not the time to have surgery. And that can be hard. I was in private practice before, and feel like you're always in competition with your neighbor. But for me, I think it's really important to make sure that the patient's nasal health is in the best shape you can get it before surgery. It helps with postoperative bleeding, and that's been shown in the literature, but it also helps with postoperative care and how the patient feels and what their symptoms are like as they're healing from surgery. So if they have normal anatomy, i.e. they don't have septal deviation, they don't have inferior turbinate hypertrophy, they don't have a concha bullosa, then I just have them on saline irrigation and intranasal steroid sprays of their choice. But if they have anything where I think a nasal steroid spray is not going to get where it needs to go, or they've been using it and still symptomatic, then I usually switch them to a budesonide nasal irrigation. And then I also assess what's the risk of having post-operative disease recurrence. And I want to know this beforehand, for patient education, to say, hey, you have a really bad disease, we're going to do this big old surgery, but there's a chance that, you know, it may not be successful. It may not be your only surgery. So setting up patient expectations, but it also keeps me alert so that if a patient is doing well and they have a setback, I know kind of why they may have a setback. So every patient who sees me will get a CBC with differential to check their eosinophils. If they have nasal polyps, they're going to get a urine LT4, and we'll talk a little bit more about that later. And they're also get an IgE. And then when they have surgery, I always check to have the pathologist check to see if they have eosinophils in their tissue sample. And I'm not sure about you guys, but my pathologist, when I came and asked them that, they about had a fit and acted like I was asking them to go get me donuts every morning. So I don't know what the struggle was. Counting an eosinophil, it's bright and pink, but many pathologists do not like to do it, nor do they like to record it. So now I'm like super obnoxious and I write, please check for eosinophils and then document. And after a couple of years of me writing that every other day, twice a week, then now they just write it. So if you are not in the kind of normal routine of checking eosinophils for your pathology or asking your pathologist to do so, you can be annoying and ask them on the order, and that usually can help. And then I always check to see if they have osteitis on their imaging, especially in the sphenoid sinus or in the frontal sinus. And if they do, then that's going to change my OR management, because I'm going to make their openings a lot bigger. So instead of a sphenoid ostium that is big enough that I can get a suction in and maybe a scope in, I might need to drill down that area, or I might need to use a kerrison to make it much bigger, because they tend to have a higher risk of scarring down and stenosing after surgery. And all this is, kind of prep to try and optimize the surgery and optimize and reduce the risk of recurrence. And then finally, my post-operative care includes using drug-eluting stents when appropriate, using oral steroids, using doing debridements. Suturing the middle turbinate has actually been really helpful for patients who have a narrow opening to their ethmoid sinus. And then we talk about the plan, especially my nasal polyp patients. I'm like, hey, you're going to see me even if you don't feel good, because I need to know how you're doing. I need to know what your scope looks like, even when you're not doing well, because once you're doing poorly, it may be too late for me to turn that around. So I'm like, if you're not going to be my best friend now, you might want to find a new surgeon, because we're going to be together for a while. And then I always look for underlying conditions. So do you have does the patient need immunotherapy? Does they need biologics? Do they need aspirin desensitization, etc.? So for each and every patient that I think I'm going to take to surgery, I go through each one of these questions kind of in my head, and then after surgery to try and optimize their care. So this is very busy. I put it up just as a reference for you guys. If y'all want to, take pictures or email me and ask me for different slides, I'm happy to give that to you. But this is from the ICAR document for 2021. So recurrent sinusitis, they did one in 16, and this is the updated one. And it basically is 500 pages summarized into this slide. So it tells you what we're recommending, what are options, what's not recommended, what we don't have enough information about, and how to diagnose chronic sinusitis. So again, it's a good reference point. And if you don't have any desire to read 500 pages from ICAR, this is basically 500 pages in a nutshell. So what is recalcitrant sinusitis? Well, the answer is we don't know. We don't have a definition of it. Sorry. We don't have a definition of it really. We kind of think it's patients who are continue to be symptomatic, even though they've had good surgery or you've given them medicine, but there's not really an official diagnosis of recalcitrant sinusitis. So what happens when you have done a beautiful surgery? You've taken them, you've figured out they need to have surgery. Everything is open. You can see those beautiful mucosal ridges. You're so proud of yourself. And then they come back 3 months later and they look like crap. So you do the Harmon, right? The Jim Harbaugh, oh dang, Ohio State has scored another touchdown on you. What do I do now? So this is kind of, the rest of this talk is going to be about what can you do and what should you do when you have a patient who is failed surgical management or has failed medication therapy. So I really like this slide. It's from Helling and Lund, and they looked at patients who had uncontrolled upper airway disease and kind of thought about why they may have this in very strategic ways. So we're going to go through a couple of these, because this is when I have a patient who's, you know, had a surgery, they're coming to see me for revision assessment or coming for the, you know, to see me, and they're still not doing well. I literally go through these methodic factors to see, do they align with any of the stuff that's on this sheet. So surgical failure rates are somewhere between 15 and 50% in the literature, and revision surgery ranges from somewhere between 2 and 24%. The causes include incorrect diagnosis, inadequate surgery, postoperative scarring, or just poor surgical technique. When I think about incorrect surgery, I'm usually thinking about one of two things. Did you operate on the wrong symptoms? So did the patient say, I have chronic sinusitis because I get nasal congestion on one side, and I have head pressure and sinus pain and pressure, and what they really had was a cluster headache, but you thought they had some chronic sinusitis, so we did surgery on a patient who has migraines, and they still have migraines. So EROS et al. Did a really cool study several years ago where they took random people off the street who had self-diagnosed themselves with sinus disease and sinus headache, and they ran the test, they did the scopes, they did CT scans, and they did a headache evaluation. And they picked 100 people who had had a self-diagnosis of chronic sinusitis with sinus headache, and 86% of them had no evidence of chronic sinusitis, but did have migraine or some type of headache syndrome. So the diagnosis, self-diagnosis itself is a pretty poor factor for understanding if the patient has chronic sinusitis. The other one is a patient saying they're having recurrent sinus infections, but really what they're having is allergic flares. So this is kind of controversial in the literature. We got good studies, half of which say allergies are a major component in chronic sinusitis and failure or continuation of symptoms after surgery, and the other half saying, no, we don't think it's that big of a deal. There's still a lot of controversy over whether or not immunotherapy should be done in patients who have allergic rhinosinusitis and also have chronic sinusitis. The next question I ask is if they have had, the right diagnosis, is did they have adequate surgery? So was there a Haller cell that was left? Did they have incomplete removal of an Agranácea cell? Did they still have a big concha bullosa or retained uncinate? And did they have what I call targeted surgery, but what they really needed was completion surgery? So I look and say, did they have a draft 2A, but they needed a modified Lothrop? Did they have big concha bullosas and they needed their turbinates either resected or trimmed? Do they still have a big septal deviation that's preventing irrigation to go in? Did they have, small openings, but they have AERD or allergic fungus, and they need bigger openings than what they were given at the time of their initial surgery? So I always figure out whether or not they had optimal surgery the first time. And then I look for other causes like postoperative scarring. So did they have maxillary or frontal stenosis, maxillary recirculation? Did they have some synechiae between the middle meatus, or did their middle turbinate completely lateralize and now they have frontal sinus disease? And then, without talking a lot about it, the other thing is, did they just have poor surgical technique and now they have lots of scarring everywhere? So then if I've assessed surgical failure based on, wrong diagnosis, not enough surgery, or postoperative healing that was poor, then I figure out, well, is there a medical condition going on that wasn't diagnosed, and that's the reason why they're not feeling well? So I kind of break this up into three things. One is, did they have an odontogenic cause? Do they have immune deficiency? Do they have systemic disease, or do they have aspirin intolerance? So I put odontogenic on here, just most of us know about it. It became a, kind of hot topic in the last 3 years or so, lots of studies on it. But most people know it's kind of this anaerobic process. Patients tend to have this after they've had a sinus lift, or they've had a root canal, or they've had some periodontal infection or odontogenic cyst. I think the important part for that is it doesn't have to be right after the procedure. So you can have had a root canal a year ago, and it may have taken almost a year to manifest as far as sinus disease. So we typically will ask those questions when it looks like it's one-sided or unilateral, but you don't need to dismiss it just because they didn't just have the surgery or the dental procedure a couple weeks ago. The symptoms, most of the time, they don't really complain about tooth pain, but they have kind of facial pain, they have postnasal drip, they have a foul drainage, that's pretty common. And then when you do a scope, they typically have this nice pus under, I call it pus under pressure, which essentially is the medial wall of that maxillary sinus almost looks like it has a heartbeat. And that, in my mind and in my patients, that gives me really high suspicion that the patient has an odontogenic cause. And they've also done some studies that showed patients who have unilateral maxillary disease by itself, about 70–80% of them had an odontogenic issue going on as well. So this is actually one of my patients who lovingly went to Costa Rica to get a root canal and then an implant put in. And this is what he came back to America looking like, with pus under pressure and facial pain and pressure and all the good stuff. So the question that happens when we're talking about revision surgery is, does the patient just need sinus surgery? Does the patient just need a proper dental procedure, or does he need both? And the answer is we don't know. So it's really controversial as to whether or not sinus surgery by itself or dental procedure would clear it. But Craig's group out of, I think in University of Washington, they looked at doing sinus surgery timing versus dental surgery timing, and they found that patients who got sinus surgery first actually had a more rapid improvement in their symptoms and also endoscopic score in comparison to those who got a dental procedure first. And they also found that a portion of the patients that they looked at when they had sinus surgery ultimately never needed to have a dental procedure to address any of the other issues going on. So again, the jury is still out, but at least there is some reasonably good evidence that says proceeding with sinus surgery to clear out that pus will make the patient feel better and feel better faster. So also you want to think about patients who may have immunodeficiency. And so these are the ones we learned in medical school: selective IgA deficiency, common variable immunodeficiency, specific antibody deficiency, and IgG. Most of us, we look at this and we say, okay, where's our infectious disease or immunologist? We don't like those words, but we do know how to refer. But I do say that you should be able to help your immunologist or your infectious disease doctor kind of lead them down the right path. And so I'm not trying to treat it, I'm just trying to lead them down the right path so that I don't send a patient there to evaluate their immune system, and instead they got a PICC line and 6 weeks of IV antibiotics. So remember, when you're looking for primary immune deficiencies, is not just recurrent infections. They need to have a pneumonia or bronchitis or bronchiectasis or some other area of the body that continuously gets infected as well. These are the labs that we typically evaluate for patients who have immunodeficiency. That is immunoglobulins, and then we're going to spend a little time talking about the pneumovax evaluation and antibody response to that. You also can get an antibody response to the tetanus toxoid. I leave really kind of flow cytometry to my immunologist because I feel like that's a little too complicated for me, but I do try and get the ball rolling for the rest of those. So when I think of immunodeficiencies, this is a really good summary that tells us kind of what the lab should look like. So a person who has selective antibody deficiency, the only thing wrong with them is that they don't respond to the pneumovax vaccination. And a person who has IgA deficiency will obviously not have IgA, but they also may not respond to the Pneumovax. And then patients with common variable immunodeficiency won't respond to just about anything. So how I usually go about assessing somebody for Pneumovax, if they've never had a vaccine before, which is the easiest way to have this happen, you actually give them a Pneumovax titer. Whether you give them 13 or 23, it doesn't matter, whatever your lab does, but you give them that, and then you have them go get a Pneumovax vaccination. You have them wait 4 weeks and then repeat the Pneumovax titers. And again, it doesn't matter which one you use as long as it's the same one before and after the vaccine. And what you should see is that about 70% of those individual titers have at least doubled in size. And if you see that, that's great. That means it's normal. If you don't see that, then that means that they likely have some sort of immunodeficiency. You also should watch out for patients who have what we call the memory immunodeficiency. I have one patient like that took us almost a year to figure out what's going on. He responded, but some of the titers actually went down at the second visit or the second lab, instead of going up or staying the same. And then we repeated his labs 6 months later, and everything was kind of back down to the initial baseline. So he actually had a memory immunodeficiency and has been doing quite well on IVIG. So then I say, okay, the patient doesn't have dental cause, the patient's immune system is working fine. So do they have a systemic disease? So I break this down into GPA, which is Wegener's, EGPA, and sarcoidosis. So since most of the people on the call know about all these things, we're not going to go into the clinical part as much as the workup part. I did want to highlight the fact that sarcoidosis is more common in the African American community, but it also is probably the least common of all these except EGPA. And most of the time they don't present in the nose as manifestations. More commonly, you guys are going to see somebody with Wegener's or GPA in your office than any of the other ones. So this is a picture of one of my patients from last week who's got a pretty severe saddle nose deformity and a very large septal perforation, and essentially has had autoablation of her middle and inferior turbinates. And she was coming to see me because she also needs a DCR, which is going to be fun because she doesn't have any good structures. So they tend to have crusting and perforations and all that other good stuff. So if I have a patient who I'm suspicious for it, I get an ANCA test, and you'll notice your rheumatology notes will say PR3 because that's the more common type that is going to be positive for patients with GPA. The other things, you can get a CVC and ESR. Again, I leave those to the rheumatologist, but I do sometimes go ahead and get the BUN and creatinine as well as a urinalysis, because if those are positive or abnormal, then that pushes my consultation with the rheumatologist to say, hey, patient has pretty systemic disease. It's important that we get them in and get them on therapy quickly. GPA, they talk about the fact that it can be misdiagnosed for many years, but also that misdiagnosis can lead to death within 2 years, especially if they have the more severe type. So the other thing that we commonly get is a consultation that from your primary care doctor or somewhere else that says they need an ENT consult for a sinus biopsy because we think they have GPA. And so just for everybody's knowledge, the diagnostic yield for these biopsies are pretty low. So to get a biopsy of just a stable perforation yields about 20%, or if not less. And then the paranasal sinus is better, it's like 55%, but then you tackle the risk of somebody having scarring after you've done a biopsy. The only thing I wanted to highlight on this slide is the fact that they have a pretty pathognomonic CT scan, and the fact that they have this double, I call it a train track. So it is a hyperintensity and then a low intensity and then a hyperintensity, which looks like a railroad track. And that is pretty common for patients who have Wegener's or GPA. There's two forms of it. There's the generalized form that will kill you. And then they also have this limited form, which is a bit more confusing and probably more like many of the patients that we have. Sometimes they don't even have a positive ANCA. It doesn't involve their kidneys. They're probably not going to die from it. And sometimes it will only manifest in the head and neck region or the airway region. That is, better for the patient, but they tend to relapse a lot more than those with generalized GPA, where they have more severe pulmonary or kidney problems. Treatments. My algorithm is to do intranasal corticosteroids with budesonide, because most of them have a perforation, so they need something that's going to get further in. Saline, mupirocin, which I usually do 1 month on, 1 month off. And then the anecdotal things like alkaloid or gentamicin or rose geranium. And the goal is just to reduce their crusting so that they can breathe better. So then there is the eosinophilic granulomatosis polyangiitis. This one, again, is rare. Patients, when they're really severe, they're going to have pulmonary problems or cardiac problems. They may even have neuropathy. This is a video of one of my EGPA patients. And honestly, he looked like, if I didn't know anything about his cardiac status and the fact that he had pericarditis, he kind of looked like my normal patients. Polyps and a little bit of mucin and a lot of inflammation, but he actually had a pretty severe case of EGPA. So EGPA actually has 3 phases. The first one is the confusing one. So this happens in your 20s and 30s, and it's like most of the patients that walk into my office. They have asthma, they have allergies, and they have sinusitis. So it's very difficult to discern them from anybody else. But then you go into the second phase, where it's called the eosinophilic phase, and that's where their eosinophils are extremely high, and they may start to infiltrate tissue and organ systems like the lungs, the heart, and the GI system. And then there's a third phase, which is the vasculitic phase, and that's where you get the skin lesions and the peripheral neuropathies. Not everybody actually gets to the third phase. Some people just stay in the second phase, even without having the actual diagnosis. So when I think somebody has EGPA, again, an ANCA panel is what you want for this one. They're going to have that MOP is going to be more elevated. The key for us to be suspicious, I think, is in the CBC with differential, because their eosinophils are astronomical. So greater than 10% of the total white blood cells, and then their eosinophil count is greater than 1,500. This slide, I think, is super important. It's a pearl that you can use for just about anybody who you're concerned about eosinophils. So you must ask about oral steroids before you get these tests, including IgE and CBC with diff, if you're concerned somebody has an eosinophil contributor to their disease, because eosinophils may disappear rapidly with oral corticosteroids. So I've had pulmonologists, I've had allergists, I've had other ENTs who have done labs because they were concerned, and then the labs come back normal, but it doesn't go with the picture. And it's because the patient is on 20 of prednisone every day, and so it doesn't look like they have an eosinophil problem. So before I get labs, I always ask patients if they've been on oral steroids and if they've been on oral steroids in the last 7 days. And if they have, then I make them wait 7 days before they get their lab draw done to make sure that it's a true representation of what's going on. And I've actually caught multiple patients with eosinophil problems because that weren't caught initially because they were on steroids when they got their labs. So this, again, treatment for EGPA, very much a rheumatology problem. Very happy to send them to my rheumatologist to take care of them. But they are, just for our knowledge, they are doing a lot more with biologics for this group of people. And so this is sarcoidosis, and this is probably the most classic patient I've ever seen with sarcoidosis. So they have a predication for being at the septum and also on the inferior turbinate, and also having these kind of like submucosal nodules in their nose along with septal perforations. And this person just was like pathognomonic for it. The issue is that otologic manifestations are only in like 10 to 15% of cases of sarcoidosis. And so the workup I just highlight here because most of us from med school remember, oh, sarcoidosis and ACE. However, it's only elevated in like 60% of patients, and you can't follow it to know whether or not a patient is in remission or whether or not you're doing a good job or whether or not their symptoms are related to their sarcoidosis, because it's not consistent with how severe the disease process is. Treatment management, saline, ointment, steroid injection of polyps, and then oral steroids. So as you know, sometimes they'll get these nodules on the skin, the cutaneous nodules that make them have worsening nasal congestion, or aesthetically they don't like the way they look. And you can literally do a better operation using high-dose oral steroids for 3 weeks than you ever could do with a rhinoplasty. So if you have a patient with cutaneous lesions and they are coming to you for evaluation or to get treatment, think of high-dose oral steroids as one of the options. And then from an endonasal or sinus surgery perspective, you're really only doing surgery if they have like expansile mucoceles or complications intracranially or significant sarcoid deposits that are blocking their breathing. Now, AERD is actually way more common than most of the time it is diagnosed. So it's just trying to put this in the forefront of people's minds so they don't get missed, because the average sinus surgery for a patient with AERD is 2.6 surgeries before diagnosis. It's not just 2.6 in life, it's 2.6 surgeries before they actually get diagnosed with the proper diagnosis. So keep that just kind of in the back of your mind as a potential option or cause of issues. Again, it's nasal polyps plus asthma plus aspirin intolerance. We use biomarkers for AERD. We do a spot test, a spot urine test at Mayo. You can also do a 24-hour urine. That's a little bit more specific for likelihood of AERD, but the spot test works pretty well as well. You can't send it straight to Quest because Quest doesn't have it. So there are special pharmacy or special labs around the country that actually do this test if you have a patient that you're suspicious for AERD. If you have a patient you think has AERD, my usual thing is to send them, do the test. If it's positive, send it to my allergist. We talk about aspirin desensitization, and then about 4 weeks after surgery, they go and they get their aspirin challenge and desensitization. The prerequisite is that their asthma is stable and that they have PFTs that are greater with the FEV1 greater than 70. There's several different ways that you can do an aspirin challenge. You can do a spray, you can do it by mouth, you can do it 1 day, you can do it 2 days, you can do an increase every hour, you can do an increase every 3 hours. It's very variable. You may want to just know for the sake of referral how your allergist does it. This is, again, we won't go into any detail, but Lalo is at Brigham's and Williams, and she's kind of the allergist expert for AERD and aspirin desensitization. So this is kind of her decision tree between doing aspirin desensitization versus a biologic. There's also lots of other options for patients who have AERD. You can do Xylutin, but you got to check their labs. It's pretty expensive. Montelukast hasn't been really shown to help, but it's really good for asthma. So if you have a patient who has AERD and they're getting aspirin desensitization, the allergist wants them on montelukast because that prevents them from having anaphylaxis. For some of you who don't know, there's actually a low salicylate diet or low omega-6 diet has been shown to have some improvement for patients. It's a very hard diet to follow. It's basically everything healthy and everything unhealthy and that you would want to eat is on this diet. But I have a few folks who do not want aspirin desensitization, do not want a biologic, and they really are very adherent to that diet, and it keeps their asthma control as well as their polyps. And then obviously biologics. So before I go to a biologic, I consider, did they have completion surgery? Did they have appropriate postoperative medication and management? Are they interested in having another surgery or not interested? And there's controversy over whether or not you should use a biologic before you ever have surgery. And then did they have surgery, but now they still need oral steroids intermittently for improvement? And then is there a contraindication for oral topical steroids? And so if these things I've checked the box for all these things, then I start thinking about a biologic. So this is a nice little table with all the biologics in their target site and how frequently you're supposed to get the injection, with dupilumab being the most frequent. So the patient gives themselves a shot every 2 weeks. This is a lot of immunology, which we won't go into detail, but I think when I really sat down and thought about it, it actually made the biologics make a whole lot more sense. So mepolizumab and dupilumab are the two that have been FDA approved for chronic sinusitis with polyps. The mepolizumab, all it does is block the IG or interleukin-5 from going to the eosinophils and making more eosinophils. Dupilumab blocks an actual receptor, and it's on multiple different immune cells to help reduce the production of eosinophils in its reactions. All my patients, when we talk about biologics, they're like, well, what are the side effects? I don't know that I want to do this. They're pretty much the same for mepolizumab and dupilumab: nasopharyngitis, oral pharyngeal pain, some headache, injection site pain, and for the dupilumab, epistaxis. So again, if you want to take a highlight reel of the important stuff, it would be kind of the 5 criteria that we talked about before surgery to set yourself up for a good, successful procedure. The understanding of the oral steroids and the timing for labs, and this slide right here, because this tells you how you assess whether biologics are working or they're not working. So this was, everybody kind of knows that at 4 months, you're supposed to assess biologics to see if the patient has improvement. But this kind of gives criteria to say, okay, you have met 3 out of the 5 criteria for improvement with biologics. So it makes sense for you to continue on and then reassess this at a year. So I think this is a really simple slide. It's a very valuable slide, and it helps patients and doctors figure out what's the best treatment course going forward with biologics, especially because they're so expensive. So what is left? Who has more energy to learn more? So there's only 3 things I talk about: drug-eluting implants, macrolides, and furosemide. Should be spray, not irrigation. So there's a steroid-eluting sinus implant that stays in for 90 days. You put it in the office. I usually check them at 6 weeks and then at 90 days just to make sure they're doing well. And the patient has to have had a total ethmoidectomy in order to have this procedure done. Then macrolide therapy, which I use for patients who have kind of that runniness. They complain of postnasal drip and congestion. You scope them. They look like they should have a sinus infection because they just have this kind of mucopurulent drainage happening. The tissues are kind of puffy, but there's no polyps, and you culture them and they're always negative. And so these patients typically don't have elevated eosinophils. They usually don't have eosinophils on their pathology, and they usually don't have allergies. And so they're actually the perfect patient to have a macrolide therapy, especially if they have any history of like bronchiectasis. So I always think about macrolides in the back of my mind, somebody who didn't have polyps, but I just can't get their tissues to look healthy and look right. And every time I look at them, my first gut reaction is, oh, do you have a sinus infection? And the answer is usually no. And so finally, furosemide, I just threw in here. I don't use it myself, but I thought it was pretty interesting, and it doesn't have a lot of, it's not getting a lot of attention, but it actually has been shown in a randomized controlled trial to have improvement in reduction of recurrence of polyps in patients in comparison to placebo. It's a nasal spray of furosemide that you do twice a day, and it doesn't come with a lot of side effects. And so our academy in the ICAR document says that it is a potential option for patients who have recalcitrant disease and recalcitrant nasal polyps. All right, we made it through. What questions do y'all have?